Good afternoon and good evening. This is Dr. Scott Worden, the TOS guy, and today we have one of our very knowledgeable and expert guests, Dr. Art Jenkins in New York City. Hey, Art.
Hi, Scott. Thanks for having me.
Today is going to be a really unique talk. I'm really looking forward to this. Art and I are going to discuss some of the cases that we've shared together over time, over a few years of working together. We'll discuss the clinical findings, the history, the imaging from both my side and Art's side, and then how we come to decisions about how to use the imaging along with the clinical data to treat the patient. So Art, take it away.
Thanks, Scott. Obviously this type of discussion it mirrors many of the same discussions that you and I have had over the years. It's how do you get from, patient calls your office and says, I got a problem, to I got a solution. And what does that solution look like? It's a long, often convoluted process. It's made even longer when a condition such as TOS is poorly understood in the general medical community. So obviously anything we can do to improve the awareness and almost in some ways simplify the process so that it's more understandable to outsiders who are forced to become insiders in many cases. So this is, an opportunity for you and I to kind of pull back the curtain a little bit on what we do behind the scenes to help our patients to get back to their lives. So just as a general disclaimer, I don't have any stock ownership relevant to today's discussion, other than the fact that I am a surgeon. So, I do make money doing surgery, and I do my best to do my best on every case. So what do I look for when I have a patient who comes in my office and says, I got arm pain, I got neck pain. Many patients even come to me and they don't have the label yet. They've come to me because their doctors have said, I'm not sure what's going on. I think they might have a disc herniation, or they've got a nerve problem somewhere. And, Dr. Jenkins, what can you do to help this patient? So the first thing I've got to do is I've got to get a good history. That's the medical term for finding out, what ails you? What do you notice as a patient? What's your story? So we look into whether it's an acute problem. Did it just happen? Did it result from an injury? Or is this a chronic or long-standing issue that just has been getting worse and worse over time? It's very important to me when I'm thinking about what is the pain generator to understand what makes the symptoms worse, what makes them better. But in particular, when I start thinking about patients who might have symptoms that at least overlap with TOS, Thoracic Outlet Syndrome, I want to make sure that I understand, are the common triggers that we associate with TOS present? Is this something that could be TOS before we say that it is? So one of the most common types of symptoms, clinical syndromes, is the patients get their symptoms worse when their arms are up. Maybe they're reaching up above them to work in a cabinet, or maybe they're typing on a computer that's above them. But this is not 100%, because there are certain subtypes of TOS that does not cause pain, and we'll get into one patient who had that finding. Are the problems with flexion or bending forwards, or extension bending backwards? That might drive my thought process a little bit more towards a spinal problem versus a TOS problem. But the two syndromes overlap so much. Classic TOS, we talk about C8 coming down in the ulnar distribution, or sometimes C7, but it can overlap with other syndromes because TOS is not a one-size-fits-all, one-stop diagnosis. So we've got to look at the whole sum and total of what the patient comes into the office with. I want to hear how they describe their pain. Is it burning? Is it a sharp creak in their joint? Is it, a type of pain that's consistent with a nerve or sometimes blood vessel impingement or entrapment? Are there any other syndromes that they've either been diagnosed with or have but haven't been diagnosed with? One of the most common issues that I have found in patients who have TOS is that there's a large percentage of patients who have a hyperflexibility, hypermobility syndrome called Ehlers-Danlos Syndrome, or EDS. It is a syndrome of some type of connective tissue disorder. There's actually 5 different subtypes. Each has a slightly different mechanism by which they're hyperflexible or hyperdynamic. But this EDS does predispose patients to having more injuries in their joints. And since the thoracic outlet syndrome is basically the basis, the base, the floor of the entire shoulder joint, injury in that area can lead to nerve entrapment. There are other conditions that are also very common, commonly associated with TOS. And one of them is a condition called Bertilotti Syndrome. And that's a congenital anomaly where you have a hybridization of your lumbosacral junction. But many patients who have that hybridization, that neither fully lumbar nor fully sacralized vertebra down at the junction, have other types of transitional vertebrae. And one type of transitional anatomy is having a cervical rib. There are other transitional and other anomalies that are congenital that can also overlap with TOS. And so we need to make sure that we look at the big picture. We identify things it could be. We then find ways to eliminate things that it is not, leaving us with a very limited set of, hopefully very limited, set of probable diagnoses that we can then test a hypothesis on. May-Thurner is another one. It's a vascular problem where there is an obstruction of blood vessels in the lower extremities. Specifically the veins coming out of the legs going back to the rest of the body can cause backup of blood in the legs. And you say, well, what does that have to do with TOS? And the answer is, you'd be surprised. Somehow or other, you get collaterals when you have an obstruction low in the venous system. You get collaterals because that blood wants to find its way back to the body, back to the heart. And there seems to be some process of collaterals that go through the whole body, come back in through the thoracic outlet region. And when those collaterals are dilated or blown up because of increased flow, patients have thoracic outlet syndrome-like symptoms. And when we treat the obstruction down in the pelvis, in some patients, their TOS symptoms get better. So these are all conditions that we need to be aware of, look for, diagnose, treat in the appropriate order to make sure that we're helping patients, doing the most for them, the least to them in the most efficient way that gets them back to life with the least amount of intervention. What else are we looking for? Weakness, numbness, pain. In particular, there's this condition that TOS has been labeled in some senses as being, whether it is, fully actuated TOS or whether it's questionable or, Scott, what's the term again?
Disputed
TOS, which is, it's a misnomer because there's no dispute that these patients have TOS. But if you don't have EMG findings, some neurologists question the diagnosis. And the bottom line is you don't get EMG findings typically when you have intermittent or reversible occlusion or you only typically get it when you have permanent damage to the nerve, not damage that is present in one position and alleviated in another. So the very often when you see atrophy, you see weakness of absence, loss of muscle, it's a late finding. These are things we want to head off, not wait for them to happen. So then that's just talking to the patient. We haven't even gotten yet to the physical exam. So in the physical exam, I will test for strength. I'll test for symmetry or asymmetry. In particular, we'll do tests where we're doing something called the EAST test. And we're looking specifically for reproduction of symptoms when the arms are up or when the arms are down, depending on which type of syndrome the patient has. We'll be looking for other signs of neurologic problems that may lead us away from TOS, like neurologic spasticity might be a spinal cord problem. Numbness, reflexes, there are certain peripheral neuropathies where reflexes drop out. And there are certain spinal problems where reflexes are exaggerated. So these are all things we have to look at to steer us to the right diagnosis for each patient.
And by the way, for the listeners, peripheral neuropathy is when you can get your nerves in general throughout your body are affected by a diffuse metabolic disease or a chemical disease or an autoimmune disease. And that can mimic TOS in certain cases, but it's just a diffuse sickness of the nerves throughout the body. It's not a focal compression or tension.
Well, actually, and maybe I was misusing the term. I was more talking about a peripheral neuropathy, maybe as like a localized neuropathic problem, as opposed to a diffuse, but that you can have both. And certainly these are, as you were saying, there when you're looking for the types of findings and symptoms, you want to make sure that you're identifying ones and identifying the probable cause of it, and not overlapping too much and assuming this thing is causing, but it's really caused by something else. So that's certainly the syndromic and systemic causes certainly need to be taken into account as well. And then once I'm drilling down further, I got the patient in front of me and I've tested their strength, and I will test often grip strength in 2 positions as well, because that seems to specifically look for TOS. I'll actually be poking and prodding them in the classic locations where the TOS can be found, because if I push in a place and it causes pain, not just for it to hurt where I touch, but to go down the arm where I touch it there, that's highly suggestive that the 2 are related. And then the next thing I got to look for, because I'm not going into enemy territory without a map, is I've got to get good imaging, and the imaging has to match the symptoms. What do I mean by that? Well, what I mean by that is there's a lot of times we see horrible looking films in patients who have no symptoms coming from that area. None. I have patients who come into my office with spinal problems that look, I look at them and I say, how are you even walking? And they're like, walking? I play golf. I play 18 holes a day. What are you talking about? And so it's, you have to make sure that the imaging matches the symptoms. But if you don't have the imaging, it's going to be really hard to justify going in and fixing something just because the patient says, yeah, it hurts here, doc. Now, what are these common entrapment sites? Well, these are places where a nerve, an artery, a vein, or sometimes more than one can be pinched, and they can be pinched by muscle, they can be pinched by bone, by ligaments, by inflammation, and they can be pinched dynamically, meaning they're pinched in one position but not in another. And that's actually very common in TOS, and before you get to really end stage condition, is that you'll have this, and you might lift up the arm, and depending on how you lift the arm and how you move the arm, you may loosen the compression or you may tighten it more. Interestingly enough, where a lot of the compression comes in, and one of the things I think makes it hard for people to understand, is why if my arm go up, does the pressure go down? And the answer is but it almost makes sense. Well, if the arm goes up, what is the arm sitting on? The arm is sitting on the chest. And so when the arm goes up, this actually sags under the weight of the arm because it's holding it up. And for every action, there's an equal but opposite reaction. So for the arm to go up, the clavicle and the scapula essentially have to go down. And so in particular, we look at the scalene triangle. We look at the costoclavicular junction right in here where the first rib crosses. We look out here where the pectoralis minor muscle is and where these vessels go under the pectoralis minor. We look in the ulnar groove here, which is also known as the cubital tunnel. And very often patients may have a peripheral entrapment here that looks like TOS and it sounds like TOS. But if you touch here and it causes their pain to go down their arm, and you touch up here and it doesn't, well, then it's not TOS. And then there's also carpal tunnel syndrome. And many patients have pain into similar distributions, and there's overlap. And if it's really just carpal tunnel syndrome, well, that's treated completely differently, and you wouldn't want to mix the two up. So here's an example. This is the first patient we're going to present today. She comes into my office with predominantly right greater than left-sided neck and arm pain. And interestingly enough, basically this all blew up when they went into COVID, and she was on her laptop constantly. And I guess her arms were up a little bit more. She's right-handed. And she failed extensive conservative management, like 6 different modalities, chiropractic, other types of physical therapy, manipulation, whatnot. On exam, interestingly enough, her right arms up and down were actually very similar in strength. And so that was one of the things that kind of maybe pushed me a little bit away from TOS at first. But there's rarely is there any one absolute exclusionary, there's no veto power on any of these things. It's all, you've got to paint the whole picture. And because she's right-handed, her right hand was a little stronger than her left hand. And that's actually fairly typical. Most people are about 10 to 15% stronger in their dominant side than they are on their non-dominant side. But she had exquisite tenderness with radiation at her scalene triangle, at her costoclavicular junction, and also a little bit with her cubital tunnel, but not as much. So is a person who now we're thinking, it seems like she has TOS, but may have some component of cubital tunnel as well. So we have to think about all of these things, but no atrophy and no gross weakness anywhere. So, well, when we're thinking of weakness or pain or radiating pain down the arm, we also think, oh, could it be a disc herniation? We checked, and she actually had a pretty clean MRI of her cervical spine. The only major thing she had is she had a minor degree of what we call congenital stenosis, but she had no area where there was a big bulging disc. Nothing was pinching her anywhere else in the neurologic system. She also did not have any cervical ribs. She had no congenital anomalies. So really, at this point, it's starting to look more and more like it's probably the TOS, because the TOS symptoms were clearly much stronger, and the reproduction with the cubital tunnel compression was really very minor compared to the other 2 locations. So, Scott, I'm going to ask you to show me the MRI, the TOS MRI that we did.
Mm-hmm.
Do I need to unshare my screen?
Yeah, I have to actually give permissions to this to share for me. Bear with me for a second. Unexpected security.
Stop screen.
Okay, let's make sure I can share here. That should work. And yeah, okay. So I'm going to have to quit Chrome, which I'm using. We're going to reopen in Firefox. So give me about 15 seconds here.
It's technology. Technology is awesome, except when it doesn't work. Well, in the meantime, so we had to have a lot of discussions with the patient about what we were looking into and what certain degree, what we could expect from surgery, and what, if we're not operating in the cubital tunnel, clearly the cubital tunnel related symptoms weren't going to get better. So this is important for us to understand and manage the patient's expectations, because, I mean, nobody wants a blanket guarantee that you can't meet. It's
all
just
right.
considerate patient treatment.
All right, you should be able to see me now. Share screen.
I see you now.
Entire screen and allow. All righty. Can you see me now?
I see you now.
Great. So our first patient on the right side, what we're showing here is actually between the clavicle or the collarbone and the first rib. We have narrowing, moderate narrowing, I called in this case, with the brachial plexus being narrowed. On the left side, we actually see some anomalous muscles with hypertrophy or enlargement of the left anterior and middle scalene muscles. And underneath them is this little muscular sling where the insertions overlap. And so there's narrowing of the scalene triangle, which means less space for the brachial plexus to slide or to move when the arms change position. Again, on the left side, you'll see the collarbone and the first rib get too close together. And again, they're causing compression of the brachial plexus. And this is just a coronal, what we call a stir image. But you can see on each side that between the collarbone and the rib, they are squeezing the brachial plexus. That's the right side. Oh, let me go back. Here's the left side. And those are the pertinent findings on patient number 1. I'm going to give sharing back to you.
Excellent. So, well, at this point, we have a roadmap. We can see where the compression is. We know that we want to be able to take away the component of something that is causing compression. And in what I have found to be the most effective and least invasive way of doing this was the minimally invasive first rib resection technique that I developed. I use something called the synaptive exoscope, which I have no financial ties with. I just like using it because it works really well for my patients. And we take what's called an infra or below clavicular approach. So we go under the clavicle, follow the first rib back, and resect it back far enough to be able to get past that anterior scalene insertion, preferably, and especially for her, all the way back to the, are you guys seeing my screen? Scott,
No,
do you see?
not.
Oh, okay. That's interesting. Maybe, technology is great, except when it doesn't work. I see what happened. I clicked ahead one too many, one little too quickly. Sorry about that.
You're back.
Now we're back. Now you can see me. Excellent. So this first rib resection minimally invasively allows me through a very small incision to take the amount of rib that is causing compression and leave the rest alone. If it's not causing problems, why touch it? So we go back about 2/3, it's about 60% of the way back on the rib, and take away where the middle scalene and the anterior scalene attach to the rib. And then that basically takes the floor out from under where the compression is between the clavicle and that first rib. And the next bone nearby is the second rib, and that's pretty far away. It allows us to decompress that CC or costoclavicular region and into the scalene triangle. And so it takes a village to do spine surgery. This was one of the intraoperative photos. This is the exoscope itself here. It's essentially a giant camera, but it's actually a 3-dimensional camera. So we're actually wearing these goggles not because they're cool, but because they give us 3-dimensional viewing of what we're doing. And so we're operating on this patient, but we're each looking at a 3-dimensional screen. And then this is the final result on this particular patient. This is actually her clavicle right here. And this is her sternal notch. This incision's about 1 inch long. So we're able to do all of this through a tiny little incision. And many of my patients actually go home the same day. So the idea is to do the least to the patient does the most. So, but, the bottom line is the proof is in the pudding. I mean, you can do a beautiful operation, Dr. Jenkins, but if you're not helping patients, what's the point? So by her report, when we saw her last was at the 3-month point, she had dropped from 5 out of 5 to 2 out of 5 in that pain on the side we operated on. We operated on the right side first. Excuse me. And she had some left-sided symptoms, but by her words, those were almost completely gone. So we do often see that there is something related to the improvement of venous flow. Getting back to that May-Thurner correlation is that if you improve the vascular circulation here and it's no longer being pinched and backing up into the arm, it's not doing collaterals through the neck and through the back to the other side. And so those veins on the other side are not as engorged, and therefore they seem to not pinch the nerves quite as much. And then we suspect that the remaining 2 out of 5 is either slow continued improvement, and that when we examine her, say in 6 months, we'll see her maybe a 1 out of 5. Or it may be that 2 out of 5 pain that she's still having may just be the completely separate and distinct cubital tunnel syndrome symptoms. So it's important to understand what you can fix, what you can't fix, and make sure that everybody goes into this without blinders on, without just assuming, oh yeah, he said he was going to fix everything. Well, we fix what we can fix. but it's important to be upfront and honest about what we can fix and what we can't, because there are patients who, when I tell them this is what I can make better and this is what I can't make better, they say, you know what, then I don't want to do it if you can't give me a home run. I'm like, okay, I'm just here to help. I am a guide. I am, it's not me who's living with this. It is you. And I'm doing my best, and I'll tell you what I have to offer. And if you want to find somebody else who thinks they can do a better job, by all means, find them. Just caveat emptor, you got to make sure that you find somebody who will deliver what they say they'll deliver. My philosophy is I would always rather under promise and over deliver than make promises I can't keep, because I think that undermines patients' trust more. There's a lot of times patients are like, well, why don't you tell me what you think you can do? And I'll try to be very explicit. This is what I might be able to do, but what you should expect is X, not 100%. Because I do have patients who get 100% resolution. I have patients who, I actually had one patient once who got mad at me because I told them, yeah, we typically see 80 to 90% resolution of symptoms, but not 100%. And they got mad at me and said, I had 100% pain relief. You should tell your patients that you, I'm like, listen, be grateful.
Could have offered to give some pain back to him, I guess.
Well, I think that patient may have, have had some other issues to work through as well. Yeah. So, when you're angry with the doctor who gave you 100% pain relief,
right?
I'm the first to say maybe it's me, but in that case, I don't think that one was me. So,
in your experience, because I think the literature is really soft on this, what are the factors when a patient walks in and needs TOS surgery? What are the factors in terms of age, duration of symptoms, et cetera, that you think are predictive of a better outcome?
Well, definitely earlier, less weakness, no vascular injury, because somebody who's had a chronic compression that has damaged the vein over and over, that vein is very likely to develop internal septations and scarring that will result in, even because some patients have VTOS, venous thoracic outlet syndrome, and they may present with a clot in that vein from the blood vessel being occluded long enough that the blood pools and clots. Now, when this happens, we go in, we take the clot out and fix the compression so that it's no longer being compressed. But the issue there becomes, if they have enough scarring inside the vein, it's going to come back, because we can't fix that permanent problem. And today in our technology, putting a stent there doesn't necessarily stop that scarring, and it does. And right now we don't have vein transplants. It's doing a bypass can work, but bypasses can fail as well. So there's no magic bullet for these things. So the longer the compression has gone on, certainly at some point older patients don't do as well, but that tends to be much more at the extreme end of the spectrum. And I think in general, as long as you give reasonable expectations of what your outcome is, most people who are considering surgery are miserable enough that they are grateful for the opportunity, rather than having unrealistic expectations. But that can go both ways. I've definitely had patients that I've had to have a conversation with that ended with, I don't think I'm the surgeon for you. So it's important to understand that it is a two-way relationship, not a one-way relationship. It has to be mutual trust. I wouldn't want to do surgery on somebody who's not going to be compliant with my post-operative plan and regimen. Why do a beautiful operation if you're going to set yourself up for failure by not doing, by going back to smoking or doing whatever it is that's going to be a problem. And so, these are the types of things that we have to consider about who is a good surgical candidate. And to a certain extent, Ehlers-Danlos patients have higher complication rates in general. And so having that diagnosis predisposes you to TOS. So that's part of the spectrum of the patients that we deal with. But it's also important that they understand that, it's not always a walk in the park, as much as we do our best to try to make it that way.
I also want to mention to our viewers, we know you have lots of questions piling up here. After we do the next case, we'll start taking questions. So be patient, hang in there.
All right, so let's go to patient 2, which is a little bit different story. This is a patient who's she's in her 50s, and she's had pain for 40 years, mostly in the right, almost exclusively in the right, with severe weakness. I mean, the right hand is significantly weaker than the left, to the point where she can't even make a C, let alone an O with her right hand. She feels faint, like she actually gets like dizzy when she lifts her arms for 45 seconds, not just weak, but faint. And she has pain that's distributed not in the classic costoclavicular compression TOS pattern. It's more of the hand than we usually see. And she actually was primarily arm pain, and 3 months ago, she started having neck pain as well. She also has a history of low back pain, which we'll need to address separately, or maybe together. We have to look into all of these things. On exam, as I said, she's unable to make a C with her right hand. She's severely weak in that right hand with atrophy of the intrinsic hand muscles. This is an advanced case and her East test was positive almost immediately. She had no compression tenderness at her pec minor or cubital tunnel or carpal tunnel. So it's not anywhere from here down the arm that the compression, it's really, she did have compression tenderness at both the costoclavicular and in the scalene region. So we looked at her spinal imaging, and lo and behold, she's also got cervical disc herniation. So now we've got to be thinking, how much of this is radiculopathy? How much of this is TOS? And so on top of that, she has this condition called congenital stenosis, where her spinal canal is a little smaller than normal at baseline. So when you throw these disc herniations in, it's even more symptomatic because they just have less room to accommodate. And these congenital anomalies often run in packs. I mentioned Bertilotti Syndrome before, because congenital anomalies in the lumbar spine often run with congenital anomalies in the cervical spine. So she has a cervical stenosis. I'm actually going to wind up looking at her lumbar to see if she has one there. We noticed that her neck in general is too straight in the upper part, and that goes along with there being some type of a problem. Her muscles are splinting. She's holding herself so stiff to keep from moving. But she didn't have a Chiari malformation, so at least we've eliminated one possible diagnosis, and there are no fractures. So as I said, we're going to look down her lumbar, and lo and behold, she has a congenital anomaly in her lumbar spine, where she has this transitional anatomy, where the transverse process down here at L5 is just too darn close to the S1, and that may be where some of her back symptoms are coming from. She also has some arthritis at other levels, including a very large, broad, bulging disc herniation. So we see that there's some things here. She does not have the venous syndrome of May-Thurner syndrome. So it seems like she's got a lumbar syndrome causing her low back pain. And she's got some problem above the thoracic spine, so either in the TOS or the cervical spine, that's causing her upper extremity symptoms. So we can separate the two at least. So I'm going to unshare and let you have the screen back, and then you can show us what she's got.
All right. Can you see my presentation, my slides?
Yes.
Great. Patient 2. As Art mentioned, one of the things we want to rule out is spinal disease. So our study, the Neovista MRI, always includes the cervical spine. These are 2 images from the right side that again show the disc bulges, the narrowing of the neural foramina, the side holes, which each allow one of the nerve roots to come out. These are at C5-6 and C6-7 on the right side, and on the left side to a lesser extent. And those are narrowing of the neural foramina. That means that each of the individual roots that come out there are compressed upon. It does not mean that they're symptomatic. Patients can have disc bulges, herniations, neural foraminal stenosis, central canal stenosis with minimal or no symptoms. This is from her right side. She's got a very broad insertion of the anterior scalene muscle, and she's got something pushing the artery, that black spot in the middle, forward and bulging that anterior scalene muscle. That is a cervical rib. Classically, cervical ribs will affect the arteries. In this case, it's taking up a lot of space that the artery and the brachial plexus needs. Without pointing it out, I can see the C7 and C8 nerve roots here, which are displaced forward and away from one another. And then here is a picture of the cervical rib, nicely shown on MRI, beneath the neurovascular bundle. So what it's doing is it's actually displacing the subclavian artery and the brachial plexus forward and upwards because of the size of this cervical rib. Now, with the arms elevated, she's got pretty advanced narrowing of the costoclavicular interval, not the worst I've ever seen. But when you look at other images that I'm not showing here, you can actually see more severe compression of the brachial plexus between the collarbone and that cervical rib. In this case, the brachial plexus is right in the middle there. And when we look on her left side, she has hypertrophy and broad insertions of both anterior and middle scalene muscles. This is a soft narrowing of the scalene triangle with, again, a muscular sling lifting up the neurovascular bundle. And she's got narrowing between the rib and the collarbone on the left side. But because she doesn't have a left-sided cervical rib, she's got a little more space to play with on this side. Again, we're pointing out the brachial plexus between those two bones. And that's patient number 2. All righty, I'm going to go back to stop sharing, and Art, you can take over again.
Back to our previously scheduled programming. So this is one of the things that I'll do sometimes is I'll get a CAT scan to look at bony anomalies, especially when I'm worried about these types of hybridization, this transitional anatomy. It's very important to understand where it is, how far it goes, and what it's impinging upon. So these are very subtle signs. In particular, this is what the three-dimensional reconstruction of this CAT scan looks like. And you can see that the one side has this longer spike. It's almost like a fang coming off of the spine that the other side doesn't have anywhere near that size of a process there. And so this is the cervical rib over here. In particular, it's represented by this asymmetry on the axial views. So the clinicians need to be able to see this subtle increased density here that's not present on the other side and say, you know what, I need to dig a little deeper here. Oops, there we go again. So what do we do now? So for her, since we've bifurcated these into 2 separate processes, we're going to address them separately just in terms of the clinical workup. So as far as the neck and arm symptoms, this has been going on for 40 years, and then the neck pain has been going on for 3 months. So something that's been going on for 40 years, the odds are it's not the disc herniation, because she probably hasn't had two cervical disc herniations for 40 years since she was a teenager. So more likely than not, the congenital anomaly is probably the major contributing factor to the arm pain that she's been dealing with all this time, and it is getting worse and is causing profound weakness in her hand. But the cervical disc in a stenotic canal is a very significant issue and could be making everything worse. And then on top of that, there's also the costoclavicular and scalene triangle impingement. To put it all in perspective, these are all 3 things that are all happening in the same space. Can you guys see my screen, my personal screen?
Yes, can see it.
And so what we're dealing with here is an impingement here, an impingement here, and an impingement here, all on the same side, all in the same patient. And what we'll sometimes see is that the cervical spine problems, because it's pushing on the spinal cord, may actually be causing more or a worsening of the symptoms in a way that you might not at first consider. And what we have found is that when this creates a phenomenon called the double crush. So when you have more than one impingement, if you take out the most proximal, the most upstream, the closest to the brain part of it first, it's about a 50-50 chance that you'll make the more distal, the more distant, the more peripheral problem feel better, to the point where they don't even want surgery anymore because they're pretty good. And so it seems almost counterintuitive that we're going to make the 40-year arm symptoms possibly better by fixing the cervical spine. And so what I find is very useful in situations where, well, which one do we do first? And, you know, some people might criticize me by saying, well, Dr. Jenkins, why don't you just do them all? Well, that's a lot of surgery to do on one person. We're going to do a first rib resection, a cervical rib resection, and a cervical discectomy infusion at multiple levels, or an artificial disc at multiple levels in the cervical spine. Either way, these are pretty big operations to do individually. Doing them all at once or in rapid sequence without waiting to see if one has more downstream effects that you can then take some gains off the table in other areas seems to be a little bit irresponsible. It's also kind of goes against my scientific upbringing and my, you know, my more classic scientific training of make a hypothesis, test the hypothesis, act on the hypothesis. So in this particular case, what we are going to do is we're going to get an injection into the cervical spine, an epidural, and see how much of her symptoms improve. If that does not give her very much improvement in her symptoms, I feel fairly confident in saying, then we'll just leave the cervical spine alone and we'll just be careful with her neck and not twist it or pinch it in a way. And we'll address the congenital anomaly first, the cervical rib. On the other hand, if she gets great response, then we'll do the cervical first, because the cervical it's an area of potential instability and it's an area of spinal stenosis on her spinal cord. So these are two potentially significant deviating pathways to take. And so I like to test the hypothesis and then act on the hypothesis. So in that particular case, we're just waiting for the results from that. As far as the back goes, they likely have this Bertilotti syndrome, and we're going to do the same thing of test the hypothesis, do injections into her back to identify how much of her back pain gets better by injecting different places. Is it the disc herniation? Is it the degeneration in the disc? Or is it that lumbosacral transitional vertebra? And we can do those by individual injections to identify which injection alleviates the pain more. Well, that's probably the single largest pain generator that they're dealing with. Plus, also, I think patients really appreciate it because they get to try before they buy. They get to see for themselves what the issues are and how much improvement we can often give. And so back to that patient management of expectations, if I give them the opportunity to see how much benefit there is, they're much more comfortable saying, let's do it because I loved how good I felt. Or it really didn't do that much for me. I'm glad you tested it first because I don't think I want to do it. It's not that serious. So it's that putting the patient first mentality of analyze, assess, test, and then implement, and then follow up afterwards and make sure that you're on the right pathway. So as I said, these are the plans for her, and we'll see where we go from that. Shall we go to the questions?
I think we should. We have people who've been waiting patiently, which I really appreciate.
Okay.
So first one from living with TOS, living with Thoracic Outlet Syndrome. Why is it that pain can come and go? For example, I can be okay with minimal pain to an onslaught of intense pain for a week or more, and then it subsides again to manageable.
Well, I think that tells me that this is a dynamic situation. We know that depending on how you sleep, you're going to put differential pressure on that shoulder, and based upon where that shoulder is, you're going to be pushing on the nerve, the artery, the vein in a way that can aggravate it. So even if you don't do nothing other than sleep, that can aggravate this. And then that's a common I know people who their arms go to sleep when they're lying on their side, or they become back sleepers because that's the only position their arms don't go to sleep in. Or it could be any kind of a minor injury or just repetitively using. Maybe I have some patients say during a period of high stress or during a period where they had to do a lot of work on the computer the very next day. And that's one of the things that's interesting that I find fascinating about the human body. Inflammation tends to build over 3 days. So you might do something that injures it, and you might not see the worst of the compression, of the irritation, of the inflammation for 2 or 3 days afterwards. So it makes it harder to say, wow, it started hurting, but you have to remember back 2, 3 days to what you might have done that irritated it. So it's harder to make that mental connection between the two. So if you get an aggravating period, think back, and don't just think back to what you did that day. Think back to what you did the weekend before that might have started that 72-hour inflammation cascade where it peaks at about somewhere 48, 72 hours and then starts to trail off again. So some of that may also be the duration of your symptoms may be in that trailing off period, or it may just be that you're waiting for that nerve to recover, and by not using it and not moving it and just letting it kind of catch its breath again.
A guy named Wartenberg in 1944 actually wrote a paper called Brachialgia Statica Paresthetica about people sleeping and developing symptoms from that. I think Todd in 1912 reported after he slept, he put his arm over his head and slept that way for a few years, trying to create a problem. And it took him like 5 or 7
God
years.
bless him.
Yeah, and then he got an arterial disease, and he got little gangrenous spots in his fingers.
That's dedication.
Really is dedication. I'm sorry to hear about these flare-ups from all the varied stories we hear from patients, and Art will support me on this. There are a million TOS stories. Teasing out the common threads is tough sometimes. Emotional components, because chronic pain has so much emotional weight and ballast for patients. It's really tough sometimes. Patients who see a bunch of doctors and don't get answers. It's frustrating as heck, we know. And then diet. We're learning a lot now from other fields about how diet can affect your inflammatory state. So, arm position when you're sleeping, your job may change. You may have different levels of stress that a normal person without the compression can live with. There's not one answer, and I'm really sorry to hear that you're suffering through that. But I would ask you, do you have a solid diagnosis yet? Do you have a plan to address the underlying mechanical issues? And maybe you can answer us back. Christoph, thanks. We've seen Christoph before. Thank you for your presentation. Thank you. Have you found good results with CBD oil or other cannabis-based products for TOS? So this is an interesting issue, Art, because as you know, people have done studies using CBD, using cannabis in conjunction with opiates to reduce the dose of opiates. It works through a different mechanism. Do you have much experience in New York with this?
So we definitely don't have much experience. I will say that there's a lot of early literature that's coming out on the use of CBD for different conditions. I've had anecdotal cases where patients have said they have found it to be useful. I've also had anecdotal cases where patients said, yeah, it didn't do anything for me. And so in many ways, until we have a better understanding of the exact mechanism by which these things work, and the full spectrum of the pharmacologic effects of the different subtypes of CBD products, it's unfortunately still very wild and woolly in terms of understanding, and clinicians like me to take and say, this is what's appropriate to do, and this is where it's not useful. I'm actually, unfortunately, I'm giving a talk very soon on the subject of reducing narcotic use after surgery, just across all surgical fields. And there's not a lot of literature on the use of CBD in post-surgical patients. You'd think that that would be great. And there's only some anecdotal literature on the use of patients who have surgery who happen to be using CBD products, not a rigorous trial of here are the doses we're using, and this is partly because many of the CBD products are not USP regulated in terms of dosage and strength and things like that. So a lot of it's as I said, it's very wild and woolly right now, and certainly anything that helps my patients, I think should be studied more within reason. But I think that, there's a lot of ground that needs to be covered before we can make specific recommendations.
And regarding that, Christoph, as you probably know, there are different mechanisms to transmit pain throughout the body. That's why opioids work on certain receptors on the nerve cells very specifically. Other things like non-steroidals, like ibuprofen, work on other ones, and cannabinoids from marijuana, CBD, work on other ones. So sometimes you can block somebody really hard in one of their receptor systems and the pain still breaks through. So people have found that combinations can work better, but it's way above my head. It's very complex neuroscience.
Well, it's also very complex math, being able to do all the different combinations to be able to answer those questions. And,
right.
and
As
so
you said, using different doses in the study.
And it takes large numbers of patients, and then it takes a large amount of time to analyze that data. So there are probably dozens, if not hundreds, of studies that are currently running to try to address these issues. But we may not see the results of those for a long time, partly because of the peer review process, and partly just because good science takes time. You can do crappy science in a very short amount of time. But that's not the type of thing I want to draw my conclusions from, because there are a lot of things like thalidomide, for example. It's a drug that was thought to be the wonder antiemetic and was being given to women, who were having, morning sickness. And guess what? It caused devastating birth defects because it was never run through the US FDA. It was being snuck into the country because it sounded good. Heroin was originally invented by a pharmaceutical company that's still in business, so I'm not going to mention it. But it was originally invented just before the turn of the 19th century, and it was thought to be a better form of morphine or opiate, better than morphine opium. They thought it wasn't going to cause addiction, that it was going to cause all sorts of great things. And guess what? It was even more addictive than what they were replacing it with. What they thought it was going to replace. And so, Goethe said the road to hell is paved with good intentions. And there's a lot of great intentions out there, both with cannabinoids and other novel therapeutic interventions. But if we don't test it with good science, you don't want to be the next thalidomide.
And I remember reading about some of these thalidomide babies in Life magazine when I was a kid. It were really devastating birth defects, missing limbs and stuff. And I'd forgotten the part about how it was snuck into the country. Bakhtiar, hi Bakhtiar, a patient we know. How do I approach my doctor to cooperate with another specialist to have a better result? What should I do when my doctor tells me we don't like you to see any other doctors? So this is an issue beyond science. Art, how do you deal with that when patients want a second opinion or they want to?
This is tough because obviously patients like this feel that they're trapped. And maybe they're trapped economically because they're in an insurance company that has very limited access to specialists like this. And so it's these doctors can take the mentality of it's my way or the highway, and there's no highway. Where possible, go find a different doctor. If this doctor's treatment strategy and fundamental philosophy doesn't align with yours, I would say that's not a good match for you. On the other hand, if that's truly the only access you have to care, then, it's kind of like you've got to find a way to get to yes, and get the care you need. There are resources to help people to try to get consultations elsewhere, but getting the physical care, getting somebody who will you can get a consultation and you can lay it in front of your doctor's face, but they have to actually read it and investigate it themselves and buy into it. And, I've often said, seeing is believing, but believing is necessary for seeing. You need to have an open mind if you want to actually learn something and move the needle forward. So I feel, great sympathy for people who feel trapped. Honestly, if this is a disabling condition and where you are is so limited, maybe what you really need to hear is maybe you need to move. I mean, it's a terrible thing for me to have to say, but if you really are that trapped, you're not married to that doctor. And, as much as you love your home and whatever, maybe you need to find a place where you can be taken seriously. Just as if you're in a bad marriage, sometimes the answer is leave the marriage. It's going to suck. It's going to be an absolute disaster, but in the end, you can rebuild. Whereas if you don't have the chance to rebuild, you're never going to make any progress. So sometimes an earthquake is necessary to shift the ground, or other times you can find a way to get to yes. You can negotiate with the doctor. You can explain to them what they've done. I will tell you, I hate it, but there are plenty of doctors out there who don't like to have the patients come in and try to educate them. There's an ego there. There's a process that these doctors assume they know everything that they need to know. They may not think they know everything about everything, but they may think they know everything they need to know. And you may need to engage that doctor and get them more open to seeing you as a human being rather than just as a patient. But I don't have a good answer to that because I don't have a magic wand that can fix that type of personality trait.
So, and Bakhtiar, that's kind of a multi-level question. Number one, do you only have one doctor you can see because of, let's say, insurance? In that case, you might ask the insurance company, the provider, for their, I wouldn't call it a bill of rights, but there are patients' rights, and they have responsibilities to provide a certain level of care. And if you feel you're not getting appropriate care from one doctor because he or she is not expert enough in a difficult condition, you should exercise perhaps that in a discussion with your insurance company, saying you don't feel comfortable, you understand it's a challenging condition dealt with by experts around the country, and maybe a second opinion is called for. Then the other part, with your doctor not willing to listen to other doctors, maybe just supportive evidence. When you tell your insurance company, I've worked with other experts and they're saying something different, I'm feeling uncomfortable that my doctor will not accept other experts' opinions. So hopefully you can work it out with your insurance company to allow you a little more flexibility. I think there's some wiggle room there, especially for a condition like this, and especially if you have documents from other doctors, like an MRI report from us, and your doctor won't use it or look at it or discuss it with me, for example, then maybe you tell your insurance company you need to open the range a little bit. And you can contact me again privately. We can discuss that further.
Yeah, I think that the fundamental issue here is everybody's responsible for their own actions. And so you may not want to take some of these earth-shaking moves that I mentioned. That's great. You have to, I can't feel what the patients, what any individual is feeling. I can only feel what I feel, and only you can feel what you're feeling. And so you have to decide what risks, what endeavors, what am I willing to do to get past this hurdle that I'm in. And for some people, they may say, you know what, I'd rather suffer with what I'm doing than upset whatever I'm doing here. And that's fine. That's your choice. But everybody has to take responsibility for their own lives. And so that means they have to do their due diligence. They have to look up. They have to check their own network. Maybe there are other doctors that they could change to who are in network. Or maybe they need to drive, an hour to find that doctor. So it's really up to each patient to figure that out. I can't give them the answer to that question, but I will tell you there is an answer, and there's probably a right answer for that person. And it may not be the options that are immediately visible to them.
Right. And as you said, some patients have to go out of network and get that expert opinion to then force their docs in network to pay attention.
Yeah, I certainly strongly support that move.
Yeah. Thank you. Christoph, is there any more probable place of compression for anterior neck, excuse me, for anterior neck, chest, and medial nerve symptom distribution?
The answer is there are tons of places, and there are tons of other pressure points. I only talked about some of the most common ones I use when specifically evaluating for TOS. Bottom line is any place where a nerve, an artery, or a vein run over, through, around a bone or a muscle or a tendon or a ligament, those are all potential points of compression. And so, you really got to know the whole spectrum. As I said, I talked about the common ones. I certainly didn't even talk about all the ones I do in my day-to-day practice.
So this is why the physical examination by a very experienced neurologist or neurosurgeon is key, separating out which nerves are involved and where they're involved. Something you have through experience, right?
And it comes with practice, and it comes with training, and it comes with, just a lot of experience. And sometimes it comes from missing stuff and learning about it and going back and learning about it again. So, you don't get there overnight to be able to do it on a regular basis, but that's why they call it the practice of medicine. Keep practicing. Eventually you get it right.
So Christoph, make sure your doc is in the right field and has enough experience you feel, or maybe get a second opinion. Neurologists spend a lot of time worrying about little tiny details, and that's good sometimes. Buddy Lee and me, I have had TOS about 16 months now, and my corrective chiropractor seems to have mostly brought it under control. That's great. However, the TOS seems to be trying to come back. Any theories on why or how to best fight back?
This is a chronic problem. It will always try to come back. There's no way that any chiropractor, surgeon, neurologist, radiologist, pain management doctor, orthopedic surgeon, cardiac surgeon, or president of the United States who can make this problem go away. It will always be there, and it will always need to be managed, and you will always need to do whatever you need to do to try to get it better. And it is what it is.
We had a question earlier from Living with TOS, right? And these flares are fairly common in TOS patients. A lot of things can happen: emotional stress, work stress, etc. If you have the underlying mechanism that causes it, readjustment of shoulder muscles and scapular positioning can help. But what we found from our experience on my end in my practice is that the patients who get through it without surgery are always aware in the back of their mind when they get the early symptoms, they know how to address it, a lot of biofeedback. And some of them can survive with orthotic vests, improved sleeping positions, reminders of posture. There's a product I've just been looking at, which is a little device that hangs over your back with a little leash around your neck. And if you lean forward for too long, it alerts you, which honestly I find myself doing too when we're at these devil's named computers. So sometimes it takes some awareness, but unless it's definitively treated, it's always there in the background. I think that's our experience as well.
And even definitively treated doesn't wave the magic wand and make it all go away magically. Surgery is just creating a different, not perfect condition, but is better, generally speaking, better than the one you started with. But you'll always have something there. And just as scars remind us the past is real, twinges of the old problem remind us when it's time to do your exercises again.
Brad Simpson. I know that usually rounded and depressed shoulders can be found with TOS, but have you seen backward shoulders and pectoralis atrophy with TOS? What could explain the entrapment then? Okay, so in World War II, there were a couple of papers written. One paper was talking about soldiers that put on backpacks when they were otherwise healthy. The backpacks reposition their shoulders, just as you imagine, backwards and downwards. The soldier's posture, not shoulders, the soldier's posture. And some of these soldiers got symptoms. It's probably due to costoclavicular compression. Remember that we've got 17 muscles around each scapula attaching it to the chest wall. Otherwise, it just kind of floats over the ribs. It's controlled by the collarbone, but thank you, Art. But you can see the collarbone can rotate and twist and turn. So losing some of the strength or tightness or tone in the pectoralis muscles, particularly the pec minor, but the pec major also, because it attaches the clavicle, can allow the scapula to assume an abnormal position. And so the point of compression may be different. And I say this all the time. I'll let Art talk in just a second, but there are many different types of TOS. And the guy who lumped them all together in 1956 made a mistake, in my opinion, by simplifying it. There are different causes. It's still TOS if that compression or stretching occurs in the thoracic outlet. Now, Art, let me defer after my soliloquy.
So what I'm showing now is on this side here, this is the side where the clavicle is in a more normal position, and there is more room for the artery and vein coming out through here. This is where the clavicle is pulled back, and as it pulls back, it's essentially drawing over that first rib, and it's really almost scissoring the artery, the vein, and what's not seen directly, but by implication, is the nerve passing through here. So you can get TOS symptoms from forward of the forward posture, which is causing a different type of problem, or with hyper pulled back posture as well. And in fact, when you roll your arm up, the first thing happens is the clavicle rotates and rolls backwards over that first rib. And that's the other factor that contributes to symptoms for a patient who gets those symptoms when the arm is up. So the answer is it's not that one is TOS and one isn't. It's just they're different flavors of TOS.
Yeah. And I'll add 2 quick points. Everybody's anatomy is different, and you have a bunch of things going on besides just bones. The anterior scalene, middle scalene hold these structures so they can't slide so much. That's why a cervical rib can contribute. So that's why we believe good imaging, along with a good clinician, makes a difference. I'm going to ask everybody who's waiting to have their questions answered. I know we've got a lot of questions backed up, so we'll try to speed up. Brad says, is there any recommended standing position if I have TOS symptoms with any position? Hanging the arms without support seems to make the symptoms worse.
I hate to be simplistic, but if it hurts when you do that, don't do that.
Yeah, the weight of the shoulder girdle pulls down and the first rib stay in place. So your collarbone are likely coming down against the first rib.
Yeah, as you said, there are 17 muscles that support the scapula. The scapula is what drives the clavicle. The clavicle may be the immediate proximate cause of a lot of the compression, but it's really the scapular instability that results in the problem, and the clavicle is just an innocent bystander that got pushed into the way. So in this particular case, your particular anatomy is probably contributing to a compression in a way, and just, listen to your body, find that better position, and get used to putting your arms in a different position instead of just hanging them. Maybe it'll be crossing, maybe it'll be getting an arm sling, maybe it'll be cross taping your shoulders, maybe it'll be putting a figure of 8 brace, maybe it'll be getting, a custom brace made. I don't know what the answer is. This, as Neo said in The Matrix, I don't know. I'm not telling you how it's going to end. I'm telling you how it's going to begin. And in your case, you're going to begin it by listening to your body.
Yeah. See a TOS expert who knows posture. Physical therapists are great at this. We also, one thing I'll add in from the 1960s, we know from arterial studies that definitely that costoclavicular interval narrows when you're standing versus when you're lying flat. Angela.
Gravity.
It seems very intuitive, I think. Angela says, do you guys do consults via Zoom, or can people be referred to you even though it's out of state? So both Art and I have plans. We do work with patients from out of state. I think it's really critical. I refer a lot of patients to Art for really great clinical expertise. It's not a full physical exam, but Art, you can get a lot from one of these visits, right?
Yeah, we can often get the ball rolling. But ultimately, as I said, it's a 3-pronged approach. There's history, there's physical exam, and there's imaging. And you really need to make sure that you have all 3, because if you go to see, sometimes if you go see a guy who all he does is TOS, all he's ever going to see is TOS. All he's ever going to look for is TOS. And you got to find somebody who will be able to identify, what if it's not TOS? What if it's cervical radiculopathy? And so you really need to make sure you get somebody, and the physical exam is a critical part. And I'll tell you, I have people come from all over the world to see me. So Very often we'll do the initial consult via Zoom or one of the various online portals that allow us to look at each other and talk to each other. But just like we had some issues today that were technological in nature, sometimes we have those issues, and we have a lot fewer technological issues when we see each other in person. So there's an enormous value to that. But there's an enormous value to at least getting the ball rolling in the right direction and ordering the right studies. And then sometimes we can, some people are willing to make the trip if they find the right surgeon who's worth the trip.
But in short, Art, you're comfortable when patients from Washington State or a place where they've seen 5 docs and no one has an idea, for them to contact you for that initial visit?
I get that all the time. I mean, it's actually, and there are multiple conditions that I treat that I hear patients say, why does nobody understand this condition? Why are you the first person who's made this diagnosis? It's frustrating for me as well, because I feel for the patients. I feel the patient's frustration. They've been through the ringer and they couldn't find anybody who could help them.
Right. Experts in diseases like TOS are not uniformly distributed throughout the country.
Correct.
Angela, feel free to contact us through the TOS MRI website, tosmri.com, and we can connect you with experts like Art. Happy to. Christoph, could you have muscle atrophy in the upper extremity because of lack of use and not nerve damage? And if there is nerve damage, does it usually involve sensory or motor permanent symptoms? I think I understand what he's asking. So first one, yes, you can have atrophy from disuse or neuropathy, even from myopathy and intrinsic disease of the muscles. Second thing, this is a really deep question about sensory versus motor. Art kind of alluded to it. It's a really involved subject, but really quickly, I mentioned there are several sciencey publications. There are several articles I've read about nerve damage. One really quickly, Susan McKinnon took rat nerves and she put very strong constricting rubber bands on them for short periods and then lighter constricting bands for longer or intermittent periods, and found greater nerve damage with the intermittent. There was a study just done that I read in cat forearms, and I'm a cat owner, so it's frustrating, but they clearly found that repetitive light impact on the nerve created more damage than one single heavy weight held for a minute. So sensory nerves are smaller. They tend to be on the periphery of the nerve. The motor nerves are larger, tend to be towards the center of the nerve. They have a myelin coat on them, which is an insulating fat. And so motor nerves tend to get damaged later. When you have any entrapment neuropathy, docs try to treat it faster if there is motor damage. So if you just have sensory changes, it's not as urgent as if you have motor changes. Those motor changes may be weakness, incoordination, or atrophy of the muscles. But yes, there is a difference in sensory and motor. And Art, do you want to take some of that away from me?
No, I mean, I think if you don't use it, you lose it. So let's say you've got, in certain cases, patients they won't be moving an arm for one reason or another, and the muscle will get smaller. The difference is, as soon as you start moving it, it'll get bigger again, as opposed to real atrophy from a neurologic injury, where there's really nothing you can do to make it bigger until the nerve itself regenerates, and nerves don't always regenerate. Sometimes they do, sometimes they don't. So it's once again, yes, it can. But in your particular case, I can't answer that question without knowing a heck of a lot more about what's going on to say, in your case, is that what's happening or not? But sure, just as, if you work out a lot, you get your muscles bigger. If you didn't use your arm at all, your muscles would get a lot smaller. And so, but understanding the difference between a voluntary, an involuntary, meaning like you're putting a cast for 6 months, or a neuropathic problem, really probably requires a more in-depth evaluation.
When you see a patient with a herniated lumbar disc, is it important to find whether there's motor weakness or not?
Of course.
Okay. That was my understanding, but just to emphasize the difference here. Bakhtiar again. Hi, Bakhtiar. Dr. Jenkins, do you consider physical therapy before you decide on surgery? And if you are deciding on physical therapy, do you have a specific physical therapy methodology that you prefer or consider?
In general, I rarely operate on non-life-threatening conditions. Cancer, heart disease. I don't do heart disease, but cerebrovascular disease where you're an aneurysm rupture. Those are emergencies. You need to operate on them, right? If you've got cancer and you got to get it out, that's something that you really can't muck around with. Almost all the other conditions, you want to manage them non-surgically before you manage them surgically. As far as the specific PT regimens, I'm not a physical therapist, I'm a surgeon. One of the things that I have found, though, very frustrating is there are a lot of PTs who don't understand TOS, and patients will come to me and say, PT didn't help. I did PT X number of times, and it did not help. It actually made my symptoms worse. And I think the reason is there are very few. So first of all, obviously, it depends on where the problem is. There's 17 muscles that support the scapula. Which one or ones are damaged in your particular case needs to be figured out and identified, and the therapy has to be based upon that. But it's really hard to do that. There are very few things that I find consistently beneficial. I think one that seems to help a lot is shoulder shrugs, because if you're in general strengthening your trapezius muscle, that's elevating your scapula. It's lifting it up without rotating it back. That seems to buy you a little bit of room on between the clavicle and the first rib. But A, it's not for everybody, and B, it's one exercise. My hypothesis is that the average PT who doesn't understand TOS will do the 10 exercises that they know in a 45-minute period, that they do their standard shoulder range of motion. And of those 10 exercises, 6 actually make the problem in TOS worse. 2 or 3 actually help. And the other 1 or 2 have no impact whatsoever. So that is what I think is going on. And so it really, there's no absolute Bible of these are the exercises that you have to do for TOS, partly because not all TOSs are the same. So you wouldn't imagine, just like no 2 car accidents are the same. You wouldn't say, well, if you've been in a car accident, you replace the front bumper. Well, what if you were hit from behind? What would be the point of that? What if the problem is they T-boned you from the side and and the frame is bent? Well, you can't have a one size fits all for patients with TOS.
And I can share our experience in the Bay Area. We have some really expert people at TOS. So number one, what Art mentioned, see a physical therapist who knows and has experience with TOS. There are a lot of surgeons out there. There aren't so many Art Jenkins. If you have TOS, you're not just going to go see a surgeon. Same thing with physical therapists. Secondly, because there's so many different causes of it, as Art just mentioned, different approaches may work. And we know from the people who have very good regimens in our area, several of them are different from the others. So you have to be aware of that. And I cannot advise you which one works best for your condition, but a good physical therapist should work with you to steer you the right way. Stephen. Hi, Stephen. In a case of suspected double crush with cervical radiculopathy and TOS/Pec minor syndrome, good question. How would you assess the relative contributions of each crush?
Well, actually, this is almost a really easy answer clinically. I mean, it's literally, it's like that question alone may very well be a 20-minute component of a larger discussion. And it may involve multiple tests. It may involve multiple examinations. It may involve, multiple imaging studies. It may involve several injections. It depends on the problem. It depends on the exam. It depends on the symptoms. It depends on the provocation. What am I doing to you that makes it worse? Is it the neck that makes things worse? Is it the shoulder area that makes things worse? These are the components that go into it. And then at some point, it's just going to come down to judgment of me saying, okay, we're doing the cervical first. Or I don't think the cervical is the big issue. I think it's the TOS. But I don't make that by flipping a coin. I don't make it because I have my Jenkins TOS app on my, on my phone. It just takes listening, examining, studying, testing, and sometimes retesting.
The second case study we did was a person who was a little older than the typical TOS patient, had a lot of cervical spine disease. So you did an epidural and you eliminated one part from consideration. So Stephen, people can do epidurals. They can do selective blocks of the pec minor. When you're as complex as this, you need to start separating out where you have the option to do so. I hope that helps. Baby Bunny, is there anyone in Canada that is recommended? We get a lot of people from Canada contacting us, Art, and several of them have seen or spoken with you or done video.
I get a lot of people from Canada who come to me for many different conditions. Many different conditions.
So it's
let me just say this: the Canadian system is a great health system, but like every health system, American health system has its donut holes. The Canadian health system has its donut holes too. And so, if you feel you're falling into one of these donut holes where you're not getting the care you need, you have, just like the person in Virginia who seemed to be concerned that his doctor wasn't listening to him. At some point you have to decide whether you stay in the system or you go out of the system. I don't have anybody that I would say is the Jenkins Neurospine stamp of approval. I don't know. Maybe Scott does. I don't know.
I don't yet, Art. And I'd love to meet one and work with one who's good with TOS. Just have not had the opportunity yet. And it may be part of the system. It doesn't handle some edge cases as well. Angela, can you recommend anyone in the Chicagoland area for TOS?
Same answer.
There is a guy named Jason Coe, I believe. And you can look him up. I don't have a lot of experience working with docs in the Chicago area. This is a person I had reached out to, and he seems knowledgeable about peripheral nerve surgery. He's a plastic surgeon, does peripheral nerve surgery, and he seemed to know a decent bit about TOS, but I just don't have a lot of shared patients that I can, vouch for one way or the other. But thanks to the internet, thanks to our technology, you can get expert consults with people like our guest.
Yeah, unfortunately, as you know, going back to the New Yorker cartoon, on the internet, nobody knows you're a dog. And on the internet, everybody's an expert.
Yes, it's true.
So, your mileage may vary. I don't make recommendations for, and I used to even do recommendations for diagnostic treatments, people I'd worked with, but then I'd send a patient to with the same condition to a pain doctor to do a diagnostic injection, and that second patient would have a completely different experience than the first patient. So I as far as I'm concerned, I can't guarantee anybody else's outcomes. I don't even guarantee my outcomes. All I guarantee is I will do my best, and that's the best that I can offer.
And then Baby Bunny also asks, tissue and muscles pressed into my spine on my right side with elevated and thickened tissue in the pectoralis muscles and the neck. It feels like a ring roped around my scapula under my armpit. I think, you need to see somebody and get a physical examination from somebody.
Yeah.
And also, we don't want to give out specific medical information for a specific patient here.
I find it very hard to examine text messages.
Apple will soon have a device that can do that, though. Stephen, if I understand Dr. Worden's view correctly, in many cases, the problem with pec minor is not direct nerve compression at the pec minor, but I'm not sure what the last part means, Stephen. So my take, continued. Indirect effects to the dynamics in the area caused by a tight pec minor. What is your view? I think he's referring to you, Art. And what would make someone a candidate for pec minor surgery? So Stephen and I have talked at times, and I'll just clarify quickly and then let you take it off with your expertise, Art. Pec minor syndrome has been pushed by surgeons in various places because the retropectoralis space between the pec minor and the chest wall has been listed as one of the 3 classic tunnels of thoracic outlet syndrome. And the imaging does not support that. The imaging in the literature and my own expertise and experience does not support that. I see very few cases of the pec minor compressing the nerves against the chest wall. it's not even against the chest wall, it's against the subscapularis muscle. The other point is that the space it's in, the retropectoralis space, is an inverted triangle, meaning the point is at the bottom and the wider space is at the top where there's a bone called the coracoid. So anything that pulls the nerves up will give them more space. And when you move your arms, the nerves are pulled up. So there's a lot of reasons why it should not be due to compression. But what I find, and I'll stop here, is that bony hook, the coracoid, sometimes the brachial plexus is pulled and bowstringed against it. That's what Stephen and I have discussed in the past. Art, with your experience, please share.
Yeah, and I know Stephen asked this question before, and about the double crush and which one is more significant. Same answer, clinically. I'll look into and I've got a couple of different ways that I examine the coracoid process. People with big pec muscles, you can actually get behind the pec major and feel right into where the pec minor is. Other people that don't have really, massive over, really bulked up pec majors, you can actually go straight through and feel. And I would agree with you that the frequency of pec minor syndrome is exquisitely low, that it is actually causing symptoms, or that it is the primary pain generator in a patient with TOS, and maybe a double crush or triple crush phenomenon where they might have a bigger problem elsewhere and a small problem here.
Mm-hmm.
But occasionally I've had a couple of patients where we've done pec minor releases and they felt better.
Mm-hmm.
And I had one patient, we did both a first rib resection and a pec minor at the same time.
Mm-hmm.
Pulled the incision over and did the pec minor tendon release. It is what it is. It's and once again, you got to have a doctor who's willing to, get in there, examine you.
Mm-hmm.
Zoom is not a method for doing these types of exams, at least not yet. Now, maybe, the metaverse will allow us to examine you more thoroughly, but I still have a feeling that nothing is going to beat in-person physical examination to get to the bottom of, the triad of history, physical, imaging.
Now, I will add that, first of all, the first guy who did a pec minor tenotomy, as far as I know, was Jerry Lord in 1950. And there have been docs over time that have documented pec minor tenotomy, releasing the tendon, works with symptoms. Now, that doesn't explain why. And there are just theories right now. But I believe because the pec minor is one of the larger struts pulling the scapula anteriorly, it may change the dynamics by either doing a selective block, an injection, which does work in some people, or by releasing it with a relatively simple procedure through the armpit and relatively low complication rate. And it may just allow the scapula to assume a different position. So thanks. That's a really good question, Stephen. Marion, excuse me. I think you mentioned you remove a portion of the first rib. I had heard if the first rib is not totally removed, it can grow back. Do you agree? Good question.
Once again, kind of depends on what you're talking about. If you remove an entire segment and you take the periosteum with it, that segment won't regrow. Could part of an end piece get a little bigger? Could more osteophyte form off of the old stump? It can, depends on how far back you cut it. If you leave the periosteum behind and just take the bone out behind, bone will reform within the whatever periosteum you leave left. So kind of depends on, what you're talking about. But, there are circumstances where bones can partially regrow. I mean, I've done laminectomies where I know that the bone has been, a certain amount of lamina has been removed, and I go back in and there's bone back where we took it out. So there is potential for regrowth, but kind of depends on what you're doing and how much you're doing. For example, the spinous processes didn't regrow. The entire lamina didn't regrow. It just, and more likely than not, it was more that the facets rehypertrophied after we shaved them down and they grew into the space where the lamina was. So it wasn't really the lamina reconstituted. So as far as the possibility of first ribs coming back, it depends on how much you leave, where you leave it, what you leave behind with it.
Let me add that you are, by talking about lamina, spinous processes, facets, talking about pretty small areas in the spine. You'd have to have a lot more bone grow back along the first rib to take up a bigger amount of space. It's something I had read years ago about this leaving periosteum bone growing back. I've just never seen it in my career. I haven't seen it happen once yet.
I think a lot of the times that people go back to a surgeon and they were told, oh, the bone regrew.
Hmm.
Or maybe they didn't take as much as they thought they took.
Or there was a lot of scarring afterwards, and soft tissue scarring can create symptoms too.
And the soft tissue scarring in the wrong circumstances can kind of calcify as well. So it's not really bone, but it's like if you start to develop a synovial like inflammatory exudate from instability in a joint, it will become like an exophytic. It will be a growing soft tissue mass that over time can calcify. So it could look like bone, like to your point.
So Marion, if you've had surgery and you're getting recurrent symptoms, there are a lot of reasons. I think this is where our imaging can help as well. But reach out to us through the TOS MRI website and we can discuss in more detail. Angela, you're so nice. Thank you. Sarah Herman, can TOS disrupt vagus nerve function? It's an interesting question.
It is. I would say the two are probably not directly related, but there are multiple other conditions that can disrupt vagus nerve function. And some of the same people who develop TOS can develop vagus nerve disruption or sympathetic disruption, which may mimic vagus nerve disruption. So the short answer is not usually, but the long answer is, but there may be other stuff going on.
And Sarah, the vagus nerve takes a little bit different anatomic course. It stays along near the carotid artery and jugular vein, which are fairly deep. The phrenic nerve, which is on the surface of the anterior scalene, I'm sure Art finds that nerve immediately on every patient. You got to be careful with that one. We've seen plenty of patients after this surgery have a paralyzed hemidiaphragm, and they have a little trouble taking a deep breath because the phrenic nerve is involved. The sympathetic system contributes to all the roots of the brachial plexus. And, patients who have vascular symptoms with TOS frequently have an imbalance of the autonomic nervous system, sympathetic, parasympathetic. I hope that answers your question. Sarah Mackenzie Pilot, 21 days post first rib, C7 rib, scalene and arterial surgery. Pain is 4 out of 5, still have left chest numbness, but I have started to feel my left arm again, but not lower. When do we stop thinking it will come back? Let me just, I had lost all feeling to my left arm after a car crash 18 months ago. Sorry to hear that. There was severe compression, arterial TOS, neurogenic TOS. Left arm went blue, then gray. Surgeon said 75% chance. I think we have more coming.
Sounds like it.
I just want to remind everybody, we can't answer specific medical cases here. Connect with us. We're glad to talk with you, but this is not the forum for obvious reasons.
And examine text messages.
Yeah. First of all, I'm sorry to hear about your car crash, Sarah. Sounds like it was pretty bad. I just think there's a lot going on here. It'd be best if you contact me. I'm glad to steer you to a doc who knows, like Art, and can get some more information and help you.
And of course, follow up with your treating physicians as well to make sure they're aware of your progress or lack of progress in different aspects of the care. And they may want to do more follow-up as well. Or they may just be saying, sit tight, wait for this to heal up. And, the details do matter.
And I believe she said 21 days. What, in general, without being specific, Art, what's the time frame for your patients to do well after surgery? How long is the immediate post-op period last before they're over the hump?
A lot of times it depends on how long the symptoms have been going on, when I expect them to get to their peak of their recovery. And everyone's different.
Okay. Sarah says 75% chance of feeling back, but how long before we call it off? They said 2 years. Okay. In general, in the literature, what's reported from surgeons is that about 85% of patients after TOS surgery feel good to great. 2 years later, it's about 70% feel good to great. That's the literature. It's in art. Would you agree?
Yeah.
For someone who
It
gets
could fall off more at 5 years.
and probably, I agree. Um, with the extensive damage you seem to have had, and I don't want to talk about your specific case. We just don't know enough of what's going on, but it just sounds like so much stuff was going on that a longer recovery period is to be expected. Again, glad to help you, but privately, not through this kind of forum.
No, but we wish you well and good luck to you. 21 days is too early to make any calls about what the long-term prognosis is. But any concerns that you have should first and foremost be raised with the doctors who have been taking care of you up until now as well. So we're happy to be a resource for you, but please, please, please follow up with your doctors. They may not be aware of these, or they may be and think that it's not as serious, and only somebody who's been inside you and understands the issues, has sat with you, has talked with you about these things, will really be able to answer those questions. I would just be guessing.
And you mentioned your arm turning blue. If that's new and not old, then you need to see someone now. If it's just turned blue, okay. Baby Bunny says, "What is the cost for an evaluation and testing for TOS? How long should a person have to stay in the U.S. when going there for assessment and treatment?" We have helped coordinate with several patients to come from Canada to see experts like Art, to get scanning done, to see other experts in different fields. It depends how comprehensive an evaluation you need. And for that, again, we ask you to contact us through the website. It takes a little bit more detail. But let me just say, we do help coordinate. I love working with Art. If there's another doc involved in Canada or Kansas or anywhere, we are always happy to talk with them. We are doing this talk. We believe very strongly that we need multiple skill sets for this challenging disease. So we gladly support visits to the U.S. to get you hooked up with the right people and the right tests.
Yeah, and if the other question is, what's the cost of the evaluation? Well, it depends on a number of factors. I mean, I know it seems like I say that a lot, but what have you already had done? What are your findings? What studies? What's the next step in the process? And so, it really will depend. If you've got 12 different medical conditions on top of TOS, well, then it might be a much more complicated evaluation. If you fell down and you fractured your clavicle and that's what's causing your TOS, well, that's actually a much more simple process. So the details matter. You can certainly, as I said, reach out to the toseducation.org. You can reach out to the jenkinsneurospine.com website. We have information there. If that's something you're interested in pursuing further, my people can certainly tell you, give you an idea what that looks like.
Yeah, that's a very good point. Maybe we need to review some imaging studies you've had. There are a whole bunch of different things as to what you might need next. But contact us. Marion again. Hi, Marion. It is my daughter. I believe they took the entire rib out, but we had asked the surgeon if he did before surgery because we had heard that. So was curious when you said you removed part. So I think what Marion's asking, and she can help clarify, is you remove part of the first rib. I mean, I know the answer to this. You can't remove all of it. It's a choice.
Well, you can. It just makes it a really big operation for no real purpose. Just as there are times, people have an appendix, and actually we now know the appendix does have some value. It's not a completely meaningless organ.
Right.
We don't just go and take appendixes out because they're there. And I don't remove the portion of the rib because my experience has been that the additional marginal work to get the rest of the rib out is not worth the risk of complications of going that deep into the spine, into the chest to get it. And so that's why I have my particular technique, my surgical technique, it's my minimally invasive technique. I will say there's no anatomy in the body we can't take out, but it always comes at a cost. Okay. And some stuff you don't want to take out, and some things there's some lines you don't want to cross because it's just not worth it.
Yeah, in the history of TOS, there have been a lot of different approaches to the first rib. Transaxillary, patient's arm is up, you go in here. Posterior approach, Claggett, president of the Thoracic Surgeon Society, in 1962 gave a speech about that, but we know that has complications where you lose muscle function. Infraclavicular, supraclavicular. So docs will make these decisions. They're kind of, you learn it from experience, from your training. There are different approaches for different reasons. There are some surgeons I've dealt with who don't really want to see imaging. They use the same technique and they take out a lot of things. They will say, I'm going to take out anything that could possibly be causing compression. And that's one approach. There are other people who will use my imaging or other imaging and say, this is the specific spot I need to get to. Obviously, I'm biased. I think that's my approach. That's why I do the imaging in such detail. But I don't think anybody that I know of, that I've heard of, has taken out the entire first rib. As Art said, it's a big procedure, more risk of complications. It doesn't accomplish anything if you know what you're going for. Now, in terms of your daughter, I presume she's not doing great. So, we do a lot of follow-up imaging after surgery to see what's left there and what's going on. So we're glad to help you with that. But I think first, it depends on whether your daughter has seen her doctor in years, or whether it's past several years and you need a new expert. Again, reach out to us, we can help. Thanks for the question. All right, so Herb, who's moderating this, do we have any other questions, or have we answered all our great visitors here? So Art, again, I got to thank you for it's always such a pleasure for me to hear and follow your thought process, especially in these complex patients. And I thank you for sharing those patients' stories and how you went through them, and for answering all the good questions we had.
Well, my pleasure, Scott. Always a pleasure working with you, and any practitioner who knows their salt the way you do, I learn things from all the time. So I really enjoy. I mean, it's what, if you do what you love and love what you do, you never work a day in your life. And to me, it's the opportunity to learn every day a little bit more, and so that every day I'm a little better than I was the day before. And so for me, this is, these are great. And sometimes these are very thought-provoking questions. And, and obviously some very, and for many of these patients, they're heart-wrenching decisions that need to be made. On the one hand, I'm delighted that we're not in a war-torn country right now. These are first world problems that we have of what expert to go to for my TOS, but TOS can be quite devastating. And it is, just because it's a first world problem doesn't mean it's not a problem. And so, we're here to help. It's what we do. And I know you are passionate about this, and I like working with passionate people. So thanks for the opportunity.
Thank you, Art. You're most kind and very inspiring. And it is a pleasure when we see these patients get better. We have an upcoming live event. We always announce this, sponsored by toseducation.org.